Hello, everyone. My name is Erwin de la Cruz. I currently reside in Dallas, Texas, and I'm presenting on behalf of the general community population in the United States. I would first like to introduce the health issue and health determinant involved in my intervention. The health determinant and health issue I'm addressing focuses mainly on cigarette smoking that is associated with lung cancer. Cigarette smoking is the leading cause of preventable mortality and morbidity in the United States, and about 90% of lung cancer diagnosis is accountable to cigarette smoking. It is a known fact that intervention strategies constitute a change process through an individual's behavior, and to succeed in promoting intervention on behavioral health risks such as smoking, techniques associated with process of change must be established. My intervention concentrates on integrated office-based smoking cessation intervention offered by healthcare providers to their patients that smoke and are at high risk of lung cancer. My target population are mainly healthcare providers. The theories applied in my intervention are self-efficacy and the socio-economic model. The benefits of an office-based smoking cessation offered by healthcare providers mainly involve the key roles that healthcare providers play to fight tobacco use. Some studies show that those advised by physicians are 1.6 times more likely to quit than those who do not receive advice from their clinicians. Healthcare providers improve the rate of smoking cessation by increasing counseling skills, incorporating reminding into practice systems, and pharmacotherapy. Smoking cessation is among the most cost-effective measures in primary care, and it will not only dramatically improve care, but it will also do so at a lower cost. With trained healthcare professionals, effective intervention guidelines can include guidelines that involve the 5 A's: ask, advise, assess, assist, and arrange. Office-based smoking cessation intervention that offered by healthcare providers have also shown to be challenging in ways. Some of these problems include physician use of clinical practice guidelines that is low in the United States, lack of self-efficacy where effective tobacco interventions are readily available but underutilized in part due to clinician training and organizational support, lack of awareness, do not use available interventions, competing priorities such as lack of time, under time restraints, etc. U.S. medical schools inadequately teaches tobacco intervention skills. Only about 1/2 to 2/3 provide assistance, and fewer than a quarter of clinicians arrange follow-ups. The objectives of an office-based smoking cessation intervention offered by clinicians concentrates on providing cessation interventions for all smokers that visit, motivating smoking patients to stop and succeed in quitting smoking, and the application of the U.S. Public Health Service's 5A guidelines on asking about smoking, advising smoking to stop, assessing the smoker's willingness to stop, assisting the smokers to stop, and arranging follow-ups. The goal of the intervention must be to complete smoking cessation because reduction provides no direct health benefits to the individual smoker. Monitoring motivational levels is the key to behavior change with smoking cessation. Highly motivated patients are more successful with smoking cessation than less motivated patients. In order for healthcare providers to have a successful offered office-based smoking cessation, providers must convey a strong message to their patients that there is no safe form of smoking or tobacco use. Clinicians should have a system in their clinics where in every practice setting should have a systematic process that's quick and easy for identifying smokers, as well as offer additional assistance that include an FDA-approved tobacco medications such as nicotine replacement therapies, behavioral support, and an ongoing follow-up, such as the application of the 5 A's. An incorporation of technology-based interventions such as electronic medical records, e-tablets to assess guidelines, and text messaging follow-ups. Providers should also carefully review responses during counseling in order to decide how to proceed on addressing cessation, such as schedule a follow-up visit, use motivational techniques to help encourage the patient to quit, or a combination of these approaches. Providers should also empower their patients and teams. In other words, encourage their entire care team to be involved in smoking cessation and improving patients' overall health, and to discuss smoking cessation visits and refer to the behaviorist. Lastly, tobacco cessation follow-ups can be conducted by the provider, behaviorist, or clinical pharmacist. In conclusion, a collaborative, intensive, and concentrated office-wide effort to integrate our healthcare systems, to include care teams such as office nursing and reception staff, must be made to identify, educate, and treat patients who use tobacco. Successful smoking cessation attempts can increase through proven brief, repetitive, directed intervention tailored to the needs of the patient in the behavioral stage. The clinician must play a frontline role because if tobacco cessation is not a priority with every patient, who else will intervene for smokers?